Very good day to you and warm welcome to Health Talk, your weekly dose of analysis of current health issues. We broadcast live from Johannesburg in South Africa. Health Talk is also streaming live on our YouTube channel. I'm your host, Dr Sello Motaung. The focus of today's show is on primary healthcare services in South Africa. And you can be part of this discussion by calling us on Johannesburg 714-6843, 6847 or 6857. But before we get into our main story, let's take a look at some current health issues making headlines. Now, the executive mayor of Johannesburg, Councillor Pakstau, recently launched an electronic patient record system called the Health Source. This integrated electronic health record system is set to revolutionize the traditional paper-based system. And very soon we'll be saying, gone are the days of lost, duplicate, or multiple patient files at our clinics and hospitals. And to shed more light on this e-health initiative, we're joined in our Joburg studio by MMC Health and Social Development, Councillor Nongceba Molwele. Councillor, welcome to Health Talk.
Good morning, Doctor, and good morning to the viewers. All
right. You know, 3 years ago, September 2011 to be precise, there was an announcement made by the city of Johannesburg, a project called GDS 2040, which in a nutshell was aimed at ensuring that the lives and health of Joburgers are taken to a higher level and to better levels by year 2040. And one of the pillars around this project was health information technology. Now, tell us about this initiative now. Is it linked to that GDS 2040 project? And if so, why has it taken so long?
Certainly, this is linked to the GDS 2040 because the GDS 2040 commits the city of Johannesburg to make sure that the residents of Johannesburg are provided with a long and healthy life. Mm-hmm. Also, it commits the city of Johannesburg to improve the primary health care services through the priority, which is about smart city, which has the concept of smart health. Mm-hmm. We are also committed to the implementation of the laws of this country. We are committed to the implementation of the National Health Act, Act 61 of 2003, and also the District Health Management Information System Policy of 2011. Okay. So this implementation of the system is linked and it is responding to that.
Okay. So but tell us a bit more about what this system entails. I mean, I believe that it's a pilot. You implementing this at a pilot site in Slovakia, correct?
As a public sector, it is a pilot. But because we have partnered with the private sector, and it is not a pilot at the private sector, so the system is about efficiency and effectiveness. Yeah. So we are piloting it as a public sector at Slovakia Clinic. Yeah. The viewers would remember that the Slovakia Clinic has just transcended from mobile to porter cabin, and it is now the state-of-the-art clinic.
Okay, so basically, in simple terms then, you will have a computer system at this clinic. So if Mr. Joe Mgomezulu, wants to consult at this clinic, there will be his information kept in electronic format on the computer system. Is that how it works?
Yes, indeed. The system is biometric. Right. It uses fingerprints. Okay. And the system also ensures confidentiality. Uh-huh. Because for the health practitioners to process critical transaction, the system requires compulsory ICD-10 diagnosis coding.
You mentioned biometric system, which then therefore says that record would belong to only one person. How does it link up to other clinics and referral hospitals in the Gauteng province, for instance?
Yeah, this is a pilot.
Yeah.
So the city has been in contact with other spheres of government.
Yeah.
We've been in contact with the provincial counterparts as well as national for the system to be linked.
All right.
Because the system should not only be linked within the facilities of Johannesburg,
Yeah.
but it should be linked within the entire Gauteng, so that when a patient moves from Johannesburg facility to Tshwane, for example, then through the finger or the biometric system, Tshwane should pick up that this customer has been seen at a Johannesburg facility.
Yeah.
So we are calling it one patient, one record.
Will it only be for South Africans, or will other, because, you know, we have an influx, or maybe not so much, you know, to use the term influx, we do have other nationalities in South Africa that also, you know, consulted our health facilities. How will that be handled?
I must put on record that this system, we have partnered with the SADC private constituency through Anglo-American.
Right.
So the system in Anglo-American, it is within the continent. So the system won't just be for South Africa. Mm-hmm. It is intended to cover the whole continent, because of the reasons that you have just articulated.
All right. Well, it looks like this certainly will improve efficiencies. Well, I'm afraid that's all the time we've had for, and thank you very much for your contribution. All right, that was
Thank you very much for the opportunity.
Councillor Nongceba Mulwele, MMC for Health and Social Development in the Johannesburg City. All right, the WHO says that Ebola outbreak is showing no signs of being contained. Since its emergence in March, this Ebola outbreak has gotten drastically out of hand and is spreading faster than ever. Take a look at this insert produced by Wandile Mufokeng.
The World Health Organization announced this week that the Ebola outbreak, which has killed more than 2,600 people, shows no signs of slowing, with 700 new cases reported in the last week. Guinea, Sierra Leone and Liberia account for vast majority of cases and deaths in the outbreak. 8 people have died in Nigeria out of 21 cases there, and Senegal has so far confirmed 1 diagnosis. In a separate Ebola outbreak in the Democratic Republic of Congo, officials had reported 40 deaths out of 71 cases by September the 15th, according to the World Health Organization. Sierra Leone sets to begin a 3-day lockdown on Friday midnight to curb the spread of Ebola, according to Doctors Without Borders. Government authorities ordered the country's 6 million people to stay in their homes from September the 19th through September the 21st, while volunteers go door to door to screen for Ebola and take infected people in hiding to Ebola facilities, according to Doctors Without Borders, which call the endeavor coercive. The current outbreak in West Africa, where the first cases were notified in March 2014, is the largest and complex Ebola outbreak since the Ebola virus was first discovered in 1976. There have been more cases and deaths in this outbreak than all others combined. It has also spread between countries in Guinea, then spreading across the land borders to Sierra Leone and Liberia by air to Nigeria and by land to Senegal. The most severely affected countries, Sierra Leone, Guinea and Liberia, have very weak health systems, lacking human and infrastructural resources, having only received emerged from long periods of conflict and instability. On the 8th of August, the World Health Organization Director General declared the outbreak a public health emergency of international concern. Healthcare workers have frequently been infected while treating patients with suspected or confirmed Ebola virus disease. As of to date, Doctors Without Borders have sent more than 420 tons of supplies to affected countries. They have over 2,000 health workers on the ground. It is the world's worst outbreak of Ebola, with officials warning that more than 20,000 people could ultimately be affected.
Right. One of the serious health challenges South Africa faces today is maternal and child mortality. It is now largely accepted that South Africa is unlikely to meet the 2015 MDG target to significantly reduce maternal mortality. A lot of obstacles still lie on the way to improving maternal and child health. Take a look at this insert produced by Unati Bingosh.
Rands have been spent on infrastructure upgrades in several Eastern Cape health facilities. Campaigns to encourage women to go for regular pregnancy checkups are also in place. Women are also accessing social grants. All of these have contributed to the reduction of maternal and neonatal mortality rate.
We are trying very hard to reduce the pregnancies of teenagers because most of the children that die, they die because they are born from the mothers that are teenagers who do not take care of them. The other intervention that we've made is in the wards where mothers that stay very far from the hospitals come early. So we've got waiting wards for mothers that who are following up, particularly those mothers that have got other diseases like hypertension.
The OR Tambo and the Alfred Nzo districts remain areas of concern despite reduction in the neonatal and maternal rate in the province. Only 1/3 of pregnant women in these areas go for checkups by 5 months of pregnancy, the lowest rate in the country. Poor access to healthcare facilities in villages are put forward as the reasons.
Now that's a very serious problem for this issue of maternal health or maternal deaths and neonatal deaths, because when very young girls are forced into marriages and they are forcibly raped, then they become pregnant when they are too young. Their bodies are not mature enough to carry those pregnancies. Many complications arise out of that. The result of that is often the death of the young person. And sometimes those are not reported because they're happening far away from the authorities. The other thing is that if they have babies, they don't have the maturity, they don't have the knowledge, they don't have the information to care for those babies in a way that gives them a chance in life. So you have the compromise of the young woman and you have the compromise of the baby.
Pregnancy complications and maternal and neonatal deaths are not just statistics for these women in these areas. Many have experienced it firsthand.
I also gave birth here in this village. There were complications because the clinics are too far. I ended up losing my baby. Losing a baby is the worst thing that can happen to a parent. I know from experience.
I
felt labor pains in the middle of the night. The clinic is too far from here, but no transport available. I was put on a horse cart to take me to the clinic. I gave birth along the way. Luckily, myself and the baby survived. I really thought I was going to die on that day.
Authorities say neonatal and maternal deaths are also linked to poverty. A leading women's support group in the province also points out to the cultural practice of ukuthwala as another contributing factor.
Now that's a very serious problem for this issue of maternal health or maternal deaths and neonatal deaths, because when very young girls are forced into marriages and they are forcibly raped, then they become pregnant when they are too young. Their bodies are not mature enough to carry those pregnancies. Many complications arise out of that.
The government, in partnership with a number of NGOs, have tackled the issue of ukuthwala with aggressive strategy which have already yielded promising results. A project called Mom Connect was also recently launched. Expectant mothers can, with the help of their cell phones, link up with experts to help them take better care of themselves and their children, improving their lives in the process. Unati Bingosh, Health Talk, Eastern Cape.
Yeah. All right, for a discussion on healthcare issues in South Africa in general, we're joined in our Johannesburg studio by a special guest, Dr. Flavor Sinkubuge, who's Senior Lecturer of Health Policy and Management at the School of Health Systems and Public Health at the University of Pretoria. Dr. Sinkubuge is also Vice President of the African Federation of Public Health Associations. Dr. Sinkubuge, welcome to Health Talk.
Good morning.
Right. And in our Polokwane studio, we have another special guest, Mr. Rampilani Murewani, who's Chief Director for District Health Services and Environmental Health in the National Department of Health. Mr. Mrewani, welcome to Health Talk.
Thanks very much, and good morning to all the guests in the studio, and good morning specifically to the Councillor MMC Mulwela.
All right. Now, in the introduction, I mean, we showed one aspect of, the current challenges that we're facing in South Africa. And obviously this being high rates of maternal and child death. So, Mr. Mrewani, if I could perhaps just start with you at our Polokwane studio to say, well, maybe from your perspective, what are the current health challenges that we face as a country?
Thanks very much for the question. The current challenges that we're facing, are many. Some of them have been mentioned by the communities that the insert showed earlier of the traditional practices, and obviously we are having challenges of human resource capacity. We're having challenges of people still staying far away from health facilities. We also having challenges of infrastructure. But if we want to go direct to the points that were raised in the insert, it would be we are aware of those challenges, and therefore the initiatives that we've just mentioned, like introduction of Mom Connect, is one such initiatives where we say, whereas we want to deal with problems at the societal level, but I think Mom Connect gets closer to allowing the patients themselves, the pregnant mothers themselves, to take over and assist in solving the problems by using the gadget, the mobile technology, to access information, to get message alerts, and so that they can be able to respond timeously when there are problems.
Yeah.
But there are also other initiatives that we have put in place as a department, particularly to try to strengthen the primary health care. And all those initiatives are a response to our own awareness of the problems that we are having. And those initiatives would talk to the move towards making clinics in South Africa becoming ideal clinics, for an example, so that anybody who walks in our clinic, they can be confident that they'll receive the services of the best quality.
Yeah.
I think let me stop here, then
Yeah.
I can,
All
so
right.
that I don't answer any question that has not been asked, then I can wait for you to answer any other questions. But
No.
I'm happy to explain further.
Yeah, no, you're doing quite well so far. But of course, we're talking about, yes, initiatives that have been put in place to address some of these challenges. If you look broadly at the quadruple burden of disease that we're facing in South Africa, are our current health systems in their current form, ideal to tackle these challenges, do you think?
To reach an ideal system, you'd have to come to a point where you'd say, for an example, as the WHO advocates, for an example, for policies such as your health in all policies, where every sector of society would make a contribution. But up to where we are, we have made greater strides. One, we have introduced the re-engineering of primary health care as one of the major initiatives towards turning around the situation, with the result that we've got the district clinical specialist teams appointed in districts, supporting clinical governance with special focus on reducing maternal mortality rates in the country. We have got the ward-based outreach teams that have been taken through training. They've been deployed in the many districts in the country. And I can talk about over 1,600 teams that are on the ground.
Yeah.
That translates into over 9,000 individual community health care workers that are belonging to those teams.
Yeah.
We have got the integrated school health program, where we are targeting the quintile 1 and 2 schools in those deep rural areas, so that the school learners can access the services. And this program was launched in Pretoria in 2012. And we're making a good move, and we've even gone a step further to encouraging general practitioners in our townships, in our suburbs, in our villages, to get contracted to government to go to the primary healthcare facilities, because we know that people still believe that when you're seen by a doctor, then that's perfect. So what we want to do, we want to make sure that these doctors are available at the lower level,
all right,
to make sure that patients are able to access the quality services. So those are initiatives for me that the system has tried to set in place to respond to the quadruple burden of diseases.
All right. Perhaps at this stage, let me invite a comment from you, Dr. Sankubuge. I mean, we have policies, we have political will in the country, expenditure in healthcare, has been reasonably okay. In fact, if not, increasing on a steady basis over the years. But unfortunately, the health outcomes remain poor. What's your response to that?
So I think a key issue actually that research has shown is that it's not really about the money that you put in, but it's how that money is utilized and where that money is utilized. So most of the African health systems actually, I think we forget we inherited a colonial health system that was meant to actually deal with tertiary healthcare, curative health services. And didn't cater to the masses of the population. So if you scrutinize really our health expenditure, you will find that 70% of the health expenditure is spent on 30% of the population. But the mass of the disease is actually with the majority of the population. So in essence, that's why I think that the re-engineering of primary healthcare is really bringing to a healthcare to be accessible to the people who need it the most, and that's where you're going to get the most gains.
I think this is an opportune time for us to go for a quick commercial break, because I want us to then get back to talk about this re-engineered private health services in more detail. All right, after the break, we now discuss primary healthcare re-engineering in South Africa. Please stay tuned.
Good evening and welcome to yet another edition of Sports Live, the show that brings you the latest local and international news, live interviews with the who's who in sport. He's the first South African to wear a yellow jersey that was at the Tour de France this year.
It's the first time that we get a boxer who's recognized by the Ring magazine as the best fighter in the planet to visit our country.
And he's very close to world record pace. And in fact, it is a new world record.
When you cross the line, what went through one's mind?
None of the four of us knew who had won. The scoreboard is always on the left, but all of us tend to the right. No, we just waited for the country to go down. RSA.
That's Sports Live, daily at 8:30 p.m. on SABC News. SABC News, we've got Africa covered.
Welcome back. You're watching Health Talk. Now, primary healthcare re-engineering forms the core of the NHI policy. In a minute, we'll show you Health Minister Dr. Aaron Motsoaledi providing a brief overview of a re-engineered primary healthcare service in South Africa. In this insert, he explains in very simple terms why prevention is better than cure and how this ethos will be introduced into our health system. Take a look.
In 2012, our government proposed a healthcare revolution, the introduction of the National Health Insurance Plan, or NHI. It's a plan to revamp our healthcare system over the next 14 years and to ensure that each and every South African has access to good healthcare.
What I want us to do, stick to the basics of healthcare, check maternal mortality, check infant mortality, check the load of HIV and AIDS, check the cleanliness of our hospitals, the drug stock outs, the infection control, etc. All of them need to be changed in the new system because we're not satisfied with them.
Including the immunization.
The backbone of the National Health Insurance Plan is primary health care.
In primary health care, you try to stop things from happening before they happen. In other words, you promote health and prevent diseases rather than just cure and payment. That's how we want to change the system.
In a well-functioning primary healthcare system, a hospital is a last resort. Clinics will play an essential role in catching diseases early and treating them. When people come to a clinic, they will get checked up for everything and are told how to stay healthy. The aim is to treat and manage illnesses before there's a need for complicated and expensive treatment at a hospital.
How many people have ever gone just to have their blood pressure checked and say, I want to know my blood pressure? Many of them only know when there is a stroke. How many of them have checked their blood sugar to know that they may be diabetic? Many of them know when they'll end up in hospital, either in a coma or with a serious complication. It's then that they are told you are actually diabetic. So primary health care means detecting those things and making people test for them before they start happening.
There are three main programs which will form the core of our primary healthcare re-engineering. The first are teams of community-based healthcare workers who will take healthcare straight to people's homes. They'll teach people about disease and find out if they have problems that need treatment.
House by house, who is in there? Is there a father? What are his ailments? Is he diabetic or hypertensive? How do you deal with that? Is there a mother? Is there a granny with arthritis? Is there a young girl who suffered teenage pregnancy? What do we do for her not to fall pregnant again? That's how they are going to work. And in other ways, there will be a mediator between communities and the healthcare system. Many people believe primary healthcare starts at clinics. That clinic is already laid. It must start in the community and at home. And that's what primary healthcare workers will do.
Over the next few years, thousands of community healthcare workers across South Africa will be trained to do this job. They'll be able to reach all households in even the poorest of townships and will be able to help people in knowing about the state of their health before it's too late. Primary healthcare re-engineering is a schools-based healthcare program where all children can get checkups and are taught about good health at school. There are 12 million school-going children in South Africa. Targeting them whilst they're young will ensure that they can grow up to be 12 million healthy adults and reduce the amount of disease our system has to fight in the future.
Close to 25% of school-going kids in the country are classified as obese or overweight. What will happen to those kids in the next 10 or 15 years? They'll be either diabetic or hypertensive. And how are we going to cope with that?
Primary healthcare re-engineering are district health specialist teams. Each health district across South Africa will have its own team of specialists. They will dedicate their time to training and offering support to healthcare workers. Through these three programs, we will strengthen our primary healthcare and revolutionize our health system.
You don't have to go to school to be a scientist or a doctor or a health worker to know that prevention is better than cure. I think that has been taught over the ages, and I don't know why we made it disappear from the mindset of people. I want to bring that mindset out into the minds of our people for every South African. Prevention is better than cure.
Huge efforts into improving hospitals throughout the country. This includes ensuring that people who run our hospitals are the best and most qualified for the job, and making sure that they are properly trained. Also, our health department has created an Office of Health Standards Compliance. This office will send inspectors to health facilities to ensure that they are meeting certain standards for 6 key areas: cleanliness, infection control, attitude of staff, safety and security, waiting time, and drug stockouts. Over the next 14 years, there will be many exciting developments in our health system, with the aim of ensuring a healthier South Africa.
We should get excited because we'll know about our health, whereas at the present moment, we'll all know when there's disaster. Just knowing about those beforehand and knowing how to protect yourself.
Maybe we just stop it there and go back to our studio in Polokwane. Mr. Motaung, we've just shown how the system is going to work, and I mean the minister quite eloquently explained. But I'd just like us to go a little deeper into, the main pillars of a re-engineered primary health care service, especially at the level of the districts. I mean, the minister said, primary health care starts at home, which obviously emphasizes the point around prevention and us moving away from, throwing money into curative services when in fact it should be the other way around, rather focusing more on prevention. So tell us about how this is going to be structured at district level.
Yeah, let me start with the ward-based outreach teams, just to take over from where the minister ended. That you see, when you have the ward-based outreach teams, the approach firstly is the community health care worker to conduct a household profile. Then when they do that, they already have a sense of the circumstances in which people live. And because in that team we have made provision to have an environmental health practitioner, a health promoter. So these are the people that start straight away. The environmental health practitioner deals already with the circumstances in which people live. Do they have access to clean water? Is the house appropriate for habitation? And the health promoter would know whether there's food production, there's food security issues. Then they start at that level. But then what they do, they also alert the families much earlier of illnesses that can afflict them and what they must do when they get sick, so that they don't wait to have complications, but they call onto the clinic to do basic screening and so that they can get early treatment or early intervention when there are problems. When the school health teams go to the schools, the teams will do checks of teeth and dental checkups, will check the ears. There will be many learners with learning disabilities or learning difficulties, also in the same school. The environment of the school is going to be checked. Do people have access to potable water, to sanitation? Then if there are children that are not well, during the screening, the nurses will then pick up the child, refer the child straight away to the nearest clinic, or they'll give them notes that they'll take home to inform their parents that they are not well.
Yeah.
Those children that need to be taught very early in life about prevention and promotive issues, those things will be done at the level of the school.
Right.
But as I said, we will start with the Quintile 1 and Quintile 2 schools first.
All right. Can I throw in a question in the meantime? Yeah.
Okay.
I'm just more interested also around, the implementation plan. I mean, there's talk of these community health care workers, the outreach teams. Clearly, they're not in place currently, and a lot of them are still to be trained. Do you want to just perhaps comment on the implementation plan insofar as these people are concerned?
Yeah, you see, now it's interesting. These teams I'm talking about is not what we're thinking.
Yeah.
They are on the ground as I talk to you.
Right.
They may not be in the deep cities for now, but they are there. I mean, as I said earlier, we have got over 1,600 of these teams across the length and breadth of South Africa. You would find them even in the deep rural district of Pixley-Kaseme in the Northern Cape. You would find them in Vembe, in the Old Venda, in Toyando, Makado, and all those areas.
So what sort of training have they received?
Abigos?
What sort of training have they received?
They've already gone through the first phase of training, which gives them skill to do basic assessment. Basic assessment, and also to try to create an alert when there's a problem. And all of them are linked to a primary healthcare facility. And each team is led by a professional nurse who has also been trained and oriented to properly manage them and work with them. So there's already a connection between the team and the primary healthcare facility. There are already over 1,000 of them that are already beginning to report the work that they're doing into the district health information system, starting with the basic assessment, including the few data that reports on maternal mortality, maternal health, and child health issues. So those reports are coming through our district health system. that is already put in place. That linking obviously with what the MMC said about it much earlier. So they're already at work.
Okay.
The school health teams, if you want to know, maybe just to take it further, the trucks are there in the districts. They're clearly marked. Each of the 10 districts for NHI pilots received 3 trucks. One for ophthalmic services to check the eyes, one for dental services, and another one for basic assessment, like your typical area where a nurse will be there to assess people. So these things that I'm talking about are already there on the ground.
Okay. Let me invite a comment from our guest here, Dr. Sinkubuge. You've heard what the Chief Director has said. Do you want to perhaps just comment around other enablers of, smooth implementation of the re-engineered primary health care services?
So one of the key issues is the recognition of what we are trying to achieve, I think, as a philosophy and broadly. And so the difficulty, I think, in implementation is who do you put in those teams? And a critical issue, actually, about primary health care is the intersectoral collaboration, because wellness of a human being is not just about having healthcare providers, in essence. So, for instance, if you take the issues now, our current issue that we're dealing with in the Africa region, which is Ebola, you're not just only needing the healthcare practitioners to diagnose, to treat, to manage, but you certainly need other role players. So in terms of implementation, one of the key issues is to determine who should be in that particular team. And one of the determinants is actually what are you dealing with? What is the community diagnosis? And so that is key in terms of implementation.
And also involving the local communities.
Absolutely, yes. Because sometimes we think that we can do our own research and say to the community, this is what you are suffering from. But the community incidentally knows what health ailments. They may not have a scientific name for them, but they'll be able to tell you.
But the other practical issue is that obviously we know there are other social determinants of health. So we have these health outreach teams going out to look out for health issues, but there are other social factors. How would that integration happen, let's say, between the different ministries now? Health on the one side, social development on the other.
So one of the key issues in a re-engineered primary healthcare system is that we're no longer talking about clinics, which are just staffed with just health professionals. We're now talking about health posts. So in this health post, we will have, for instance, if you take in our country, one of the huge burdens of disease is TB. And in TB, we're talking about housing, access to medicine and that. So we should be able to have somebody who will be in that health post who will address issues of housing and ventilation and everything else.
All right. Let's go for a quick commercial break, and when we return, we'll now look at the role of personnel in primary health care services. Please don't go away.
South Africans survived 2014. Many of us actually were given bursaries by state-owned enterprises, but the state shrunk, telecom was privatized, and now you are sitting with huge unemployed people, but huge backlogs in terms of infrastructure that could develop the same young people.
It's in our hands, and our future is up to us. It's a tough year, and tough decisions will have to be made by the government. It's an election year, which makes it difficult to make tough decisions. It's tough to make tough decisions. It's especially tough in an election year.
That's Rights and Recourse, Sundays 2 p.m. on SABC News.
The Swaziland Tourism Authority invited Kaleidoscope on a media tour of what has become known as the Little Switzerland of Africa, the Kingdom of Swaziland. The Mantanga Waterfall is one of Swaziland's best known and most accessible waterfalls, as it can be seen within 50 meters.
That's Kaleidoscope, Sundays 5:30 p.m. on SABC News.
SABC, sharing 20 years of inspiration.
Welcome back. And I believe we have a caller from the Eastern Cape. The name is Dubula. Hello, Dubula. Hello, Dubula.
Mola right?
All right. You through to Health Talk. Do you have a question perhaps for one of our guests?
Yes, it's not a question, it's just a comment.
All right.
I just want to say that this is very important that I'm listening to now in your program.
Yes.
Because as listeners, that is what I thought about a long time before that. This healthcare should be implemented even at schools.
Right.
For instance, to avoid these teenage pregnancies,
Yeah.
like family planning should be taught at schools by the health department, not only by the teachers.
Yes.
So I just want to make that comment.
Very valid comment, and thank you very much for that. And I'm sure our guests have taken note of what you said. All right, thank you very much.
All right, thanks a lot.
Now, successful implementation of a primary health care service relies heavily on accessible and available services to all in need, irrespective of their geographical location or social status, amongst others. Now, limited resources, lack of infrastructure, staff shortages, under-trained staff can often make this implementation difficult, if not impossible. Take a look at this insert produced by Thando Ngumalo.
Many remote and farm communities regard primary health care offered by clinics as a bridge too far. For many, this service is unreachable. Those who reach it are dissatisfied about many things. Staff shortage is one of them. Many challenges obstruct primary health service delivery. Mpumalanga is one of the provinces experiencing some of these challenges. By primary health care include undertrained staff, shortage of medicine, poor roads, clinics being very far for serious cases and emergencies. Another province affected by staff shortages is Polokwane. Staff shortages lead to delayed patient attention in healthcare centers. Remote and rural patients have to wade through poor road infrastructure. For them, getting to a healthcare center is a challenge. One of the interventions government has come with is NHI, which is aimed at eradicating most of these challenges.
The National Department has come on board with the resources, and then in the next year we'll be able to roll out all the infrastructure. Once we are done, we'll be able to take it to other districts.
Of challenges as a province, as we're quite aware that we're a rural province. One of our challenges is shortage of staff. We can't attract more people, more professional in our province. In most cases, we have got this one, and they transfer, they go to cities. That is our main challenge. Our second challenge is that we don't have enough facilities, especially in rural areas and farms. We use mobiles in some of the areas, which if there's rainy season, it is very difficult for our mobile clinic to reach our communities and farms. This is a very serious challenge.
These problems affect patients who use public clinics every day. Other challenges are proximity, which in turn impacts on mortalities. The use of door-to-door community health workers is very minimal. Many remote and rural communities have none. This has led to unnecessary complications and deaths. Does the Department of Health have an intervention plan to boost primary healthcare service in these areas?
All right. We're still continuing our discussion with our two guests, but before that, I believe we have another caller on the line, and this is Khotso from Johannesburg. Khotso, welcome.
Thank you, Doc. And my question actually is based on teenage pregnancy,
Right.
which is something that we also trying to prevent, because we don't want a situation where we have a lot of teenagers that are pregnant, and we're more concerned about the future of the country, of the economy, and their future most importantly. If they are allowed to go to school, what message are we sending to the rest of the other teenagers that are there to learn and, you know, to prosper in life.
All right.
I know they have a right to education, but can't they be, you know, be sent to some special school instead of being around other teenagers that are not pregnant?
All right. Very interesting question. Thank you very much, Khotso. We will try and get some response from some of our guests. But perhaps before I do that, let me welcome another special guest from our Devon studio, Dr. Stan Molwabi, who's the Healthcare Management Executive at GEMS, or the Government Employees Medical Scheme. Dr. Molwabi, welcome to Health Talk.
Good morning, Dr. Motaung, and good morning to the viewers.
All right. Just before we get to, you know, the reason why we have you is just to dispel this myth that primary health care equals the public sector. And I'd like to invite some comments from you with regards to the role of the private healthcare sector in primary healthcare services. But perhaps, I don't know if you heard the caller from Johannesburg on teenage pregnancies. Perhaps as a start, you could ask about the role that the private sector can play in terms of, you know, preventing this problem of teenage pregnancies.
Well, with regard to preventing teenage pregnancies, I think the critical thing is education.
Right.
It is all about educating the population out there that something like teenage pregnancies is a reality, because we know from a lot of publications that there is participation in sex at early ages. So we do need to educate our learners out there that the consequences, obviously, of indulging can be pregnancy, and we need to educate them how they can prevent pregnancies. And I think the important thing is education.
All right.
With regard to the role of primary health care, the role of the private sector in primary health care remains critical. We do have healthcare providers out there who are rendering the services of primary health care, and largely we have them in the form of family practitioners who are interspersed within the community. So it is an important part of the delivery of primary health care that there should be participation of the private healthcare providers.
Mm-hmm. All right, let me invite a comment from Dr. Senkubuga. Your comments on the role of private health care and perhaps going back to our caller as well.
So one of the key things, and I really like the discussion on the fact that primary health care is not just about public. So one of the key pillars in primary health care is actually the fact that it has scientifically sound and technologically advanced. And our colleagues in the private sector have got, that's the honest truth, better technology, and they're quite advanced in terms of the science. And so that's why I always say that we can't work in silos, and we have to have partnerships. And the partnerships have to be informed that what are we partnering on. And one of the key areas that we can partner with the private sector is to leverage on the scientific advantage and also the technological advantage.
Yeah. One of the criticism leveled at our healthcare system is the fact that the current two-tiered system is unsustainable. I mean, when you're talking primary healthcare services at a public institution versus at a private, at a private level. I mean, obviously at private level, you're talking at the level of the GP. Maybe let me ask Dr. Molwabi to say that, the minister just now said primary health care starts at home. And by the time somebody gets to a general practitioner or family practitioner, it may be a bit too late. Your view on how the private sector can extend this to a level below the family practitioner?
Well, not that I'm disagreeing with what the minister is saying. They're family practitioner, and that is why they are referred to as a family practitioner. It's an integral part of the team that takes care of the health of the population at primary health care level. So we will, the correct structure is that of having that community health worker, the nurse practitioner, who will then refer to a family physician when it is the right time. So the emphasis should be that each and every ailment should be treated at the right level of care. Now, what is happening at the moment is that we will have a mother who has a child who has fever, and they decide that, well, I've got a child who's sick, I need to see a pediatrician. And that is really what we are trying to correct with the care coordination that we're starting to talk about at primary health care. What we are introducing is that we should coordinate care in a manner that the level of care that all our the population receives must be at the right level. At the moment, a person goes to a specialist even when they are not supposed to be going to a specialist.
All right. Okay. Thank you. I believe that we have another caller on the line, and this is Kanye from the First Ladies Foundation, and she's calling us from KZL. Kanye, good morning and welcome to Health Talk.
Good morning. Well, I've got a message which the Tobeka Matiba Zuma Foundation would like to basically send through to the current show that you're having at the moment, which talks to what the foundation supports as well, or education and what have you. But what our Madam Zuma wanted me to actually also express the importance of retraining our nurses at a district level on primary health care to change their attitudes as well, to say people, when they ask for these services, they shouldn't be told that, no, you only have to come only when you're sick. If there's nothing wrong with you, then there's nothing that we can do for you. You know, they need to be retrained to be more compassionate, and also their attitude should also be more on prevention. And echoing what the minister is trying to achieve on the primary re-engineering of our primary health care. But also of importance that Madam Zuma would like me to express to you is that even the community, our people, need to take responsibility on ensuring that they take charge of their lives, they change their attitudes. They can't have an attitude of saying, Minister cannot tell me what to do with my life. Minister cannot tell me how much alcohol I should be consuming. Minister cannot tell me to stop smoking. Because the very same people are going to come back to the hospitals to say, Minister, I need dialysis. So we support, and we also do the same in ensuring that we raise our health literacy, that people should take charge of their lives, strengthening our prevention, being better than cure, which is the old saying.
Thank you very much, Kanye. We unfortunately,
are happy with the program that we have. Thank you so much.
Yeah, thank you so much. Sorry to interrupt you so rudely. We just have run out of time. And thank you. Very valid comments indeed. All right.
Thank you.
As discovered in our discussion, staff morale at health facilities may be very low for a variety of reasons. But some health workers find ways of coping with the stress. Take a look at this inset.
Health workers in the Eastern Cape Hospital refuse to be gloomy and depressed by the lack of resources. Having forged unity at all levels in their hospital, they also have time to dance. These workers have devised creative and entertaining ways to fight inner conflicts of helplessness. The saying that if music be the food of love has turned into if music be the food of the soul. They find relief, comfort, joy, and spiritual upliftment in each other and the music they play, the music they dance to, only for a short time.
Is the name of a dance we do down Johannesburg way, and everybody starts to move as soon as Pata Pata starts to play.
Okay, on that note, we say goodbye to our special guests, Dr. Senko Buge, Dr. Mrewani, and Dr. Stan Mulwabi. Gentlemen and ladies, thank you so much for your contribution, valuable contribution indeed. It's unfortunate that, on an important subject like this, we need a little more time, but unfortunately we don't have all the time. So on that note then, thank you so much. And we can only hope that, there's the future looks very good, especially with the current level of commitment out there. All right, we want to thank you very much for spending your time with us. And remember that besides the live streaming on YouTube, you can watch a repeat show at 2 p.m. and 10 p.m. every Saturday. And please join us again next week, same time, for our next informative show. So it's goodbye from me and the rest of the crew here at Health Talk. Have a fantastic weekend, and please do take care.